Hey everyone, welcome. Look, if you're gearing up for your exams, you already know that traumatic brain injuries are incredibly high yield. So we're going to dive straight into mastering this highly testable topic for your upcoming NCLEX exam. My goal today is to take a subject that honestly often feels totally overwhelming and break it down so logically that you won't even have to memorize it. You'll just intuitively understand it. This awesome material comes to us straight from the team at Complete RN Solutions. They completely specialize in comprehensive nursing education, and we're going to be using their brilliantly structured framework today. Later, we're going to have this whole complex topic organized so clearly in your mind, you'll literally remember it forever. Okay, tell me if this sounds familiar. You're grinding through practice questions, and you feel like the exam just keeps asking about head injuries, specifically to trip you up. Well, you definitely aren't alone in feeling that way. The exam absolutely loves to test your ability to differentiate between conditions that sound, incredibly similar but require vastly different clinical responses. But hey, here's the absolute easiest way to categorize and remember them. We're going to build our knowledge layer by layer, and we'll start right from the tissue itself. All right, Section 1, Tissue Injuries. We're looking at concussions and contusions. So let's dive right in with the fundamental brain tissue injuries. Think of a concussion as a jarring injury, like imagine vigorously shaking a snow globe. It's simply the brain getting shaken around inside that hard skull. And because it's a shaking injury, the patient may or may not actually lose consciousness. Now compare that to a contusion. A contusion is an actual physical bruise directly on the brain tissue itself. Because there's physical bruising to that super delicate tissue, it's significantly more serious than a simple concussion, and you're often going to see it occurring alongside other severe brain injuries. So just remember, shaking versus bruising. Keep that fundamental distinction clear. Moving right along to Section 2, the 4 types of skull fractures. Moving out from the delicate brain tissue to the hard bone protecting it, let's talk about how the skull itself takes damage. The NCLEX absolutely loves asking you to identify these 4 specific types of fractures, so lock these terms into your memory right now. You've got linear, which is just a simple, clean break in the bone. Depressed, which is exactly what it sounds like. The bone is actually pushed inward toward the brain. Then there's compound, a really severe break that actually exposes the brain to the outside environment. And finally, comminuted, where the bone basically shatters into multiple fragments. Whenever you're assessing a patient with severe head trauma, these are the structural compromises you're actively looking out for on their imaging. Section 3, Hematomas, Epidural versus Subdural. Okay, now we've reached what is arguably the most critical and highly tested part of this whole explainer, differentiating the major hematomas. We are going to use 2 foolproof memory tricks to make sure you literally never confuse these 2 again. Here is your first golden rule. Whenever you see the word epidural on your exam, I want you to immediately think E is for epidural and E is for emergency. Seriously, say it out loud while you're studying if you have to. Epidural equals emergency. Let's break down exactly why that is. When we compare these side by side, the contrast is honestly extreme. Let's tackle the epidural side first. Remember our E for emergency rule? That's because an epidural hematoma is an arterial bleed, typically caused by a torn middle meningeal artery, bleeding right between the skull and the dura. Because arteries pump blood under really high pressure, this is a massive surgical emergency. The classic presentation you absolutely must know is a temporary loss of consciousness, followed by this sneaky lucid interval where the patient seems perfectly fine, and then, bam, a terrifying rapid deterioration into a coma. On the flip side, we have the subdural hematoma. Here's your second memory trick. S is for subdural, and S means slow. This one is a venous bleed happening under the dura, usually caused by the tearing of tiny bridging veins. Because veins are under way lower pressure than arteries, the symptoms of a subdural hematoma develop much more gradually. So keep that straight, arterial and emergency versus venous and slow. And finally, Section 4, internal brain hemorrhages. So, we've covered the tissue, the skull, and the spaces around the brain. Now we need to differentiate 2 distinct types of internal hemorrhages. First up is the intracerebral hemorrhage. This is exactly what it sounds like. Intra meaning within, and cerebral meaning the brain. This happens when a blood vessel ruptures inside the actual brain tissue itself, causing bleeding directly within that brain structure. Now contrast that with a subarachnoid hemorrhage. This occurs when there's bleeding specifically into the subarachnoid space. And while this can definitely happen after head trauma, it's also very famously caused by a ruptured cerebral aneurysm. So, the crucial point here is how this presents clinically. The key identifier you absolutely need to remember for your exam is the patient's description. Patients suffering a subarachnoid hemorrhage will often explicitly describe it to you as having the worst headache of my life. If you see that exact phrase pop up on a test question, warning bells should literally be going off in your head, pointing straight to a subarachnoid hemorrhage. Let's lock those core mnemonics in one last time before we wrap up because they are truly the secret to nailing these questions. Remember, epidural equals an arterial bleed, which means an absolute emergency. Subdural equals a venous bleed, which means slow symptom development. With these clear, structured distinctions in your toolkit, are you feeling ready to pass with total confidence? You can always check out Complete RN Solutions for more straightforward NCLEX, EKG, and nursing education content just like this. But before you go, I want to leave you with one final thought to test your brand new knowledge. If a patient walks into your ED after a head injury, talking to you normally, saying they feel totally fine right now, are you going to just send them home? Or are you going to remember the deceptive lucid interval of a deadly epidural hematoma? Think about it. Keep that in mind and happy studying.